All right, the time is now 12:02. Again, thank you all so much for joining today's Public Health Discovery Seminar Series. My name is Cassietta Treywick. I go by Cassie. I'm one of the admission counselors here at the City Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And today I have the honor of introducing Dr. Valeria Paz. And so thank you all so much for joining. We will have a Q&A session at the end of Dr. Pazadan's seminar series. So feel free to drop those in the Q&A chat. And Dr. Pazadan, let you take it away.
Great. Well, thank you for joining me today. I'm a professor in the Celia Scott Weatherhead School of Public Health and Tropical Medicine in the Department of Tropical Medicine and Infectious Disease. And for the past 10 years, I've been directing the Proyecto Precáncer, which is a project about using implementation science to reduce cervical cancer mortality. And we'll be getting right into that. I want to say the title of my talk is Reducing Cervical Cancer Mortality Along the Amazon River Communities Through Implementation Science. This is a picture from our window of our office. Let me make sure I can move to the next slide. So when we started in Iquitos, Peru, and I will show you where Iquitos is, but it's in the rainforest. When we started in Iquitos, Peru, we started showing our collaborators this image, and we said, this is where Peru is at. I don't know if you can see my cursor, but this is where Peru is at, this blue line. The rest of the world is these red little dots. And South America, cervical cancer incidence was at the orange straight lines. And we said, is this acceptable to you guys? Because even within South America, we have a very high incidence. And we use this to actually become our narrative. It guided a lot of the discussions because we started every one of our conversations saying, if we think we're doing well enough, let's remember this slide and say, we can do better, and let's use it to motivate us to improve the system in Peru. And within Peru, you also see a lot of variation. You see that there's places where, like Tumbes and Ica, which are located on the coast of Peru, where the cervical cancer mortality is fairly low, but then you see areas like Loreto, which is in that rainforest region of Peru, where Iquitos is located, where it's 5 times the national average. And the talk today will focus on what we did in this state, chosen specifically because we knew it had major challenges that we needed to address. So one of the questions with implementation science is like how to move evidence-based interventions and strategies to practice, like taking that research into practice in a systematic and generalizable way. One of the questions that guides this is like, if we're not obtaining the results we want to see, if we're seeing a high cervical cancer incidence, if we're seeing high mortality, why don't we pause and think about what could we do differently? Because we keep doing the same thing over and over again, and we expect the results to be different when we don't really reflect on our actions. So that's the guiding principle or guiding question throughout this presentation. But before we go further, I wanted to give you a little bit of this context. Loreto is the largest state of Peru in this left map. You see that it's the coast of Peru has got one big freeway that connects it, and it's coast and it's a desert. Then we have the Andes that go through where my arrow is going, which go north to south. And then all this region where Loreto is located is rainforest, and it's a primary rainforest, which makes it really hard to get there. The only way to get to Iquitos, now look at that second map, is by airplane or by boat. If you take a boat, it takes several days to get to Iquitos. There's no way to drive there. The only buses you have there are constructed on site because there's no way to get there. And the only highway in this entire state that's in green here is between Iquitos and Nauta, where that circle is. So it just shows you that we're dealing with like, and I'm not talking about rolling green hills and prairies. I mean, it's a rainforest with mosquitoes and mud and rivers, and it's quite a difficult terrain. So this may help explain some of the difficulties we see in this area. This is another view from our office. This is one of the tributaries to the Amazon River. Those yellow boats you see there are the school buses that they use. Here's another photo. Now, not all of it is river. We also see some urban and peri-urban areas. This is a typical construction of a neighborhood in Iquitos. This is another area, and you see these stilts because the river, when it goes up, it might reach that level. And then when it goes down, you see all the trash that's accumulated because it doesn't really have it doesn't have a good sewage system, etc. And this is within the city. Most people are transported in these rickshaws because this is the main form of moving around, considering that it's hard to get buses and cars around there. And some street scenes of chicken being sold in the market. So this is the context, and I want you to just remember this is where we're working at. So what is the evidence? So implementation science is about moving the evidence into practice. What is that evidence that exists? So the WHO Cervical Cancer Elimination Initiative says we can reach elimination, and they've defined it as less than 4 per 100,000 cases of cervical cancer. If we vaccinate 90% of girls for HPV by the age of 15, so that's the 90%. If we screen at least 70% of women at 35 and 45, and a lot of countries have decided to do it every 5 years instead of like twice in their lifetime. And if we ensure that of the women who are positive or who are at high risk for developing cervical cancer, like an abnormal pap smear, or they have a positive HPV, if 90% of those with cervical disease are treated. So that's the 90-70-90 elimination initiative. And the talk today is going to focus on the 70% and the 90%. We did not work at all on the HPV vaccination component, but we worked on how do we improve the screening and treatment in one specific network within this large state that I've just described. Now, there are numerous ways to screen and treat. In a regular population, you're going to have 2 to 3% are going to have a NIC 2 or 3 or SIN 2 or 3. So that's like a precancer or cancer. There are different ways to screen. Many of you have heard of pap smears, but there's also, especially in lower and middle income countries, they use visual inspection with vinegar, basically, where they spray it on the cervix and they look for acetyl white lesions. And then there's HPV testing. And if you look at that, like the sensitivity of this test is so much higher because you're looking for the virus that will lead to cancer, right? Having the virus doesn't mean you have cervical cancer. It means you have a persistent infection with a virus that, if it's not taken care of, could become a cervical cancer, but not necessarily. The body sometimes eliminates it. But if we only rely on pap smears or VIAA, which is why the WHO doesn't recommend these as part of that initiative, you also see that their sensitivity is very low. So you're not catching all the abnormal cervical cells that you be catching because you're basing it on the training of the person who's looking at that cervix or the slide. So they recommend the HPV testing, which is what this project is going to be talking about. Then they recommend doing triage. So after you do an early screening for detecting as many cases as possible, there's the triage, which is often done by magnifying the cervix with like this colposcopy. And then there's a treatment, which depends on the kind of situation that you find. So when we started our project, we created a mental model that we would all be using to think through this system continuously and to make sure that we all had our same vision of what the system should look like. So this system said we have a target population of women with some kind of precancer or cancer, where we're going to find a 2 to 3%. There's going to be some kind of primary screening test, which in Peru at that time was pap smears or visual inspection with acetic acid. Those who screen negative return for screening at any time between 3 to 5 years. 3 years if it's a pap smear or a visual inspection with acetic acid, or 5 years if it's an HPV test, but at that time that wasn't happening. And if you screen positive, you go to a diagnostic triage. And at that time in Peru, the recommendation was to go get colposcopy. And then if the colposcopy did not find any lesions or did not find anything, they'd say, come back in a year just to test because we know that you are at slightly higher risk. But if they did find a precancerous lesion, the idea was to treat. And we use this mental model to remind people that only screening does nothing. Finding that you have abnormal cells and doing nothing will not save your life. we need to make sure that if a woman gets screened and there's something abnormal, she needs to get to that follow-up. Otherwise, your whole prevention system is for nothing, right? So in this case, what we examined and what we found is that, let me go back. Well, I'll describe what we found. And so as we got involved in this project, we were thinking, okay, let's start with a leading question that's going to guide us. And the question was, what is the best public health strategy? And I'm saying public health because we're not looking at what is the best for each individual woman. Somebody who has private insurance, who has a car, who has a phone, who can keep a calendar, might have a very different situation than somebody who has to navigate 2 hours in a boat, who doesn't have internet, etc. So what is the best public health strategy, population level strategy for cervical cancer prevention and management that is feasible in this context, that is acceptable in this context, and that is equitable because we all have different circumstances. Considering the system challenges and cultural challenges and geographic challenges that we're facing in this region. So as we set out to do this, and as we set out to do our project with using implementation science, we looked at a lot of the different frameworks that are used in implementation science, and we didn't find anyone that told us how to do this. There were a lot of ones that helped us think of what to think about, or what things to consider the internal setting, and consider the policies, and consider this and consider that. But we were like, but how do we start? So we developed our own framework, which was a process model, and we called it Inspire, and it's published, so you can see that that publication here. And it consisted of 4 phases that we carried out throughout this project. And every time we ran into a problem, we just started over again. And the first phase is understand the problem. We can't start finding solutions until we understand the problem. And, sure enough, we found fragmentation and duplication, no data. The second step is find leverage. Using that data that we have found, using that information, what are some options that we have? The third stage, I'm going to go into more detail in these, so I'm going to just skip over what it says. But after finding leverage and making, thinking about all the different options, it's like, let's start planning strategically. And that means getting people together to figure out how we're going to implement this. And then the fourth stage is, once you implement, learn and adapt. Have your monitoring and evaluation data, keep an eye on what's happening, and every time you find a new gap or a new barrier, go back to that first step and say, okay, what is happening and what do we need to fix? We ensured that the whole project was participatory. And when I say participatory, I meant we were working at all different levels, from women in the communities to the Peruvian Ministry of Health, to the midwives working in the cervical cancer system, to regional leadership. It was all professions, all levels of care, different decision-making power levels, but all of us with that shared goal. Let's make this system better. So let me start with this little graphic that I always start when I talk about this phase 1. And what this graphic, you imagine 6 people who are blindfolded, and they're all trying to discover what the problem is, or what the animal is. And in this case, it's an elephant. But because everyone is touching different parts of the elephant, they all have a different impression of what they're dealing with, right? So I always tell people when I'm talking, is like, okay, imagine you're touching the ears, and you think, oh, like I'm dealing with like a bat or something, like it's fluttery and it's soft, and it's, and then somebody else is touching the trunk, and they're thinking, oh, it's a snake. I'm dealing with a snake. So I asked you guys, if you think you're dealing with a bat, how would you take it out of the room that you're in? You might run, but you might also grab a net, grab the bat, and get it out. If you think you're dealing with a snake, you might not use the same net. You might use a broomstick and push it out. So the bottom line is, we should not start trying to solve problems until we understand truly what we're dealing with. And if you talk to the doctors or the midwives, they might say, the women don't come. They don't worry about their health. They're not coming. If you talk to the women, they say, every time I go to the primary level, they don't have speculums, and I have to go buy it, and I don't have it. If you talk to the lab technicians, they say, well, the samples that come here are not in good shape. So it depends who you're talking to. They will describe different problems. And we need to maybe sit together and describe all the problems, not blame anyone, but recognize that until that whole system works, we're not going to fix it. So, and we need to make sure that we have a good understanding of it. So moving beyond that elephant, what we found is within our 17 health facilities, with the 45 midwives in that system, who are the ones who do the screening, and we had 20,000 women of this age group, we found that only 31% of women were regularly getting screened. That means that we were losing 69% just at the get-go. 69% were not regularly getting screened. So that means 69% of those CIN2s that we're trying to look for, or those precancers that we're looking for, are just going to be missed. But we also found there was no monitoring system that allowed us to figure out of those who had an abnormal PAP, how many are coming. There was limited training. A lot of the midwives weren't trained to do VIA. They only knew how to do PAP, or some of them knew how to do VIA, but not PAP. So that was hard. The average number of PAPs that were being done per month by midwife were about 6, 5 VIAs. There was no HPV testing. Pap smear results could take months to get back, and there was just a lot of fragmentation, duplication, where the pap smear gets lost, you need to come back. And if you're if you have a cervix, you don't want to have to come back and get that test done regularly, right? And in the later part of the mental model, we were finding that when women were being sent to get colposcopy, only 45% were making it to that diagnostic triage. And of those that were making it to triage and were being referred to treatment, only 13%. So again, people might say, oh, these women, they don't care. They're not taking care of their health. But what we were finding is that they were taking 6 to 7 attempts just to get to triage, because the number of barriers, like that, they have to go in person to make an appointment. Well, when you live in the middle of the jungle and it's 2 hours to get to the highway and then 1 hour to get to the hospital, just to make an appointment, and then you come back for your appointment, it turns out that the doctor is in Lima getting a training, or is out for the day, and you have to make another appointment, etc. It's a lot of effort, and there was a huge loss of these patients at the hospital. In addition to that, during the time that when we were starting, there were no oncologists, there were no oncological surgeons. The pathologist was on sabbatical for the year. So in the entire state, and you saw that picture at the beginning, in that entire state, there was not enough resources. And there was no standard way to get back to women about any follow-up that they needed. So this is what we started, right? We started with this mental model, and we use it to guide our dialogue, and we obtain data to be able to share with them what we were dealing with. And people's comments were stuff like, thanks for shaking us up. We were only focused on screening, and we were not even asked to report on the follow-up. Or our heavy workload made us only pay attention to our own area, which is why we weren't thinking about the broader picture. So we started, in this process of making it visible, we started with, a chart like this one on a board. But as we started drawing it out detail by detail by detail, this is an example of how complicated the system was. Like how many times a woman has to go to a health facility, to the hospital. These points in red are where there was no standard processes. In one hospital, it's one way, and the other hospital, it's a different way. And you just see like the amount of delays. These red spots are the delays, these pink ones. Redundancies were these green ones, like they'd go to the hospital and they would get a repeat exam before they even got to colposcopy. So it was complicated. And as one of the health authorities said, once you see it, once you see the problem, you just can't ignore it. We knew there were problems in our system, but we didn't realize they were this bad, right? So once we depicted and understood the nature of the problem and we shared that, we started the process of finding leverage. And finding leverage means working together to try to start figuring out what can we do about it. So we started debating problem areas and causes, and we facilitated deliberative dialogues. And you can look up this word that I've underlined because it's about thinking about the pros and cons of these current system processes. And, if we do it this way, what will happen? If we do it that way, what will happen? We also started transferring evidence-based knowledge about solutions using bidirectional knowledge exchange. And what do I mean with this is we might have experts on HPV testing or HPV screening, and what does it mean, and what can you do to follow up? You can use ablative therapy, you can use this or that. That's fine, we can have experts, but no one is more of an expert about the context than the health professionals that we were sitting at the table with. So we made sure that everyone is an expert in a different way and in different areas, so that we would really use the contextual knowledge to really guide decision making. And we also used a rapid scenario analysis. I'll show you a little bit of that, and implementation outcomes to assess each decision. So at each decision, we're asking, like, okay, if we make this change, will it be feasible? Is it acceptable? Will it be sustainable? Right? So here's an example of a scenario analysis. It's a very simple, like, depiction of, like, if I do my system like here in the second column that says base case, if we continue doing PAP to culpa to treatment, what percent of impact will I have in treating the women with precancer? And you can see that based on the coverage and based on the sensitivity of the test and the specificity of the test and the number of people who come to triage and the number of people who come to treatment, and we even increased this from what it really is, you're reaching less than 1% of the women that you need to be reaching, right? If we did an alternative where we said do HPV straight to treatment and you skip this triage, you're going to be treating about 55%. So some minor changes will really have a huge impact on the decisions that you're making. And so this scenario analysis was really used to be able to quickly just say, okay, what if we change this? What if we change that? What impact will it have on the number of women getting screened and treated in time? And this tool became one that now the NIH has set up, the NCI, where you can be from any country and you can test in different assumptions. Like, I don't think my screening coverage would be 40%. I think it's 60%. Great, stick it into this model, try it out for yourself. The other thing that we found very helpful in decision making was using these swim lanes where we had, like, okay, this is happening at the HIV unit. This is happening at the obstetra consultation office. This is happening in the lab. This is happening in the procedure room, and where we would plot out all the different steps. And the purple stuff here is like the forms, the documents that are being used, because we found that when we did our initial assessment, there were 67 documents being used for the whole process. So you can see the amount of paperwork that doesn't finish up on anything. And so as we map it out, because this is the first page of it, and then there's a second page of it. But as we mapped out the swim lane, as we mapped out the swim lane, I'm going the wrong way, just a second. As we mapped out, wait, what's happening here? As we mapped out the swim lane, how do I go back? Okay, as we mapped out the swim lane, we can see, like, we would be asking, okay, look at this stuff. Where could we reduce some steps for the women? Do they need to go from getting their sample to taking it to the lab and bringing it? Or can somebody else do that? Can we just remove steps where we can? How will we remove it? Who will do it? Who will guide that? We were also asking along the way, okay, if we make this change, if we take out this one step, is it sustainable? Will it be acceptable? Or will somebody say, no, you can't do that? Is it appropriate? So this tool was very helpful. We would put the swim lane up on the board, and we'd have people sit around this tool, and they would just start marking up on it. And they would tell me, yo, you can go sit down. We'll figure this out. So it was a very, like, engaging tool. And this was a decision that they made. This is like us working through the tool. Their decision was, let's do HPV testing, because even though it's more expensive, it's once every 5 years. So we only have to reach, like, almost half of the goal. If they're positive, let's not send them to colposcopy in the hospital where everyone is getting lost. Let's send them straight to a visual inspection with a doctor. So they get HPV test, you're positive, okay, come back to the primary level. A doctor will look at your cervix. If you're eligible, meaning we don't see anything suspicious of cancer, we don't see any lesion, we will manage it right there in the primary level with ablative therapy, which is when you burn the cervix. If we see suspicion of cancer, if we see a large lesion, if we can't visualize the cervix, only then you will refer to colposcopy at the hospital level. So you're basically saying, I'm going to try to manage more at the primary level because we know less people will get lost. And we will only refer those who truly need a specialist to the hospital. So we started the process, and this is our monitoring and evaluation. What we see, I don't know if you can see the arrow, but what we see is that in yellow, you have visual inspection with acetic acid, which the green line, which is the HPV testing, was going to replace. The red line shows pap smears, and it shows that we were pretty consistent, didn't really change significantly. What we see is we started monitoring the system 18 months before we started, and we see that VIA, the goal that they had to reach was 390 women a week, a month, and they were way below the monthly screening goal. Once we incorporated HPV testing, since it's every 5 years, there's the goal per month is 233. It's a lot lower. And what we see is that once we started right here in June, July 2019, we started with 3 health facilities. We immediately see an increase. We started with 6 health facilities. We see another increase. And then we got to the 17 health facilities by December. And you can see how we were above our monthly goal within weeks of starting in each of the health facilities. And we see this huge jump where we're above our goal for a few months until COVID-19 hits. And then we see the first fall. So, but you can see that very quickly, like we got to the metric we were trying to get to. Then we also see other system failures, if you want to call them. We see a second wave of COVID. Then we see another point where we're below the screening goal, and it's because we couldn't get the materials on time. So what happens with materials in LMICs is, first of all, the low and middle income countries, they cost more because they have to be transported from a higher income country. So transportation costs, customs, to get them through customs, a lot of times there's costs involved and time. And a lot of the equipment that we had, if you have a cartridge and a cervical swab, they expire at different times. So all of a sudden you get the swabs, but you don't have cartridges available. And then the cartridges arrive, but these are about to expire. So I know it seems ridiculous, but these are major problems in trying to sustain programs in LMICs. But overall, using Ministry of Health data for the last five years, you can see the impact that that molecular tests have had on reaching higher amounts of women. And it hasn't been consistent. We see big jumps up and big jumps down, but it has truly been able to increase the number of women getting screened. What happens with women getting follow-up? Remember, I was saying that, there's no point of screening if you don't do follow-up. Well, before we had done this screen and treat approach, we were sending everybody to colposcopy, and we were seeing that only like that 73% were getting lost in follow-up. So the ones who actually reached a completion of care, and we are overestimating here, was about 26%. Whereas when we sent women positive for HPV to ablative treatment through that visual inspection and treatment, 67% were getting to completion of care. And the ones that weren't is because they weren't coming. 90% of the women who were being seen at that primary level, 90% were able to get ablative therapy on the spot. And so we were only referring like less amounts of women. And really, we almost tripled the care completion. So we were really proud of this. Great. And then we saw that the jump in how many women were getting screened increased in urban areas, but look at the increase in the rural and the peri-urban areas where we have the lowest income individuals, the people with the highest challenges. We see that they're that's where that HPV testing really came in handy. And this green line shows the percent that self-sampled. We see that in the rural areas, self-sampling got close to 95%. That meant that the woman would take her own test, like the midwife would be able to reach the community, say, here's a cervical swab, go to your house, swab yourself 3 times around and, insert the cervical swab, bring it back, and I will have a result for you in a week or 2. And we see how that really helped, and that the self-screening was very acceptable to women. So, you see that equity issue. So in this process, we generated evidence, we answered unknowns, we showed it can be done in Peru. We got this one about what are the challenges with follow-up care? We addressed issues of stigma. We saw what the knowledge and practices were. We saw the perspectives on this new screen and treat. And we developed a lot of evidence. And this whole time we were working very closely with the Ministry of Health, because we needed to build, we need to know what kind of questions they would have, or what kind of, like, well, we don't think self-sampling will work. Okay, let's give you the data that you need to with evidence, just data. But as we got to there, we were questioning to ourselves, is this enough? Are we truly reaching the women who are living in those remote river communities far into the Amazon rainforest? And what do we do? Like, what do we do about adaptation and scale up for equity? How do we reach those women? Because if we can't reach them with our project, like, how are we going to do it? So one thing that came up during our discussions with local providers is that there's a program called Plataforma Itinerante de Acción Social, which is basically these ships that you see in this screen, as well as this little airplane, is part of a system that goes to tries to reach remote communities that live along bigger rivers, and they have banking services. They have sign up for birth certificates, death certificates. They have a platform that helps people in these communities be counted, have a voice, have a number in the system. And they have doctors that go on this. Well, usually it's one doctor and one midwife, and they have a small consultory, if you want to call them. They have a small lab. So we asked ourselves the question, could we put like one of our machines onto one of these ships? And these ships, remember I showed you the map of Iquitos before. Here's Iquitos. Here's the only highway we have to, to Nauta. But these are a lot of the ship routes. You see this yellow one, Yawas. We see Putumayo, this one in red at the top border with Ecuador. That's one of the ships that we put our HPV testing equipment on. You see all these different routes. The Pastaza, that's another one that we also did. So you can see how these ships are reaching areas that normally people living there would not have like access to. So we set up a Gene Expert because it's a portable device for HPV testing. We did training of trainers. So the people that we had already trained for our HPV testing, screening, and follow-up helped to train some of the people on the ships that were going to be going on the ships. We trained them on giving results, on screening, on how to use a thermal coagulator to burn the cervix. It's very portable. We ensured we had data collection. We systemized processes. And then they made certain adaptations. For example, they saw that if they sent a community liaison a day or two ahead of the ship arriving, that people in those communities were informed and would come to the ship to get their testing. We also found that we spoke to the APU, the chief of these indigenous communities. There would be more acceptability because that chief would give like permission or encouragement for women to go get tested. So whereas once upon a time in these ships, they might do 5 pap smears in the course of 6 weeks. And you would even ask, why would they even do 5 pap smears, considering the women would probably never, ever get follow-up? The reason they would do it, is to kind of be able to say we did 5 pap smears, but a lot of times the ship would not return for another year, and let alone try to find the 5 women that they did a pap smear on. So compared to 5 women in 6 weeks, we managed in per average, we were doing 65 to 70 women screened in the 6 weeks. That resulted in 330 women getting HPV screened. 12% were positive. And of these positives, rather than leaving them hanging, we got them onto the ship and they received a visual assessment to determine if they could be treated on the spot. And 36 of them could, and they got ablative therapy. 4 were lost to follow-up. 3 of them had gone back to their community in the time that they were going to get the result. In one case, the partner didn't want them to go back. In 2 cases, they had gone to their community. We couldn't find them again. And one of them was suspicious of cancer. So they got a referral to go to Iquitos, but when we went to follow up 2 months later, they had already passed away of cervical cancer, which is part of the motivation to keep going, right? So we found that this PS program was very successful, and the national director was very excited about this and started talking about the possibility of using this point of care technology, not only for cervical cancer, but also for other diseases, HIV, tuberculosis, other kind of infectious diseases. We've also heard from professionals in other countries nearby about the possibility of scaling up to their remote regions. And so we have a lot to celebrate, right? We were saying, gosh, Iquitos was the first region to even use thermal ablation. And this is the little equipment that is used to burn the cervix. It's portable, whereas before they used to use these cryotherapy, which requires nitrogen tanks. This you can put in a little carry on and take it down the river and use it, and it's charged with electricity. Iquitos was first region of Peru and maybe one of the first in the world to set this up in this ships for these remote regions that are only accessible by ship or by small airplanes. And the other things that we celebrate is the fact that the Ministry of Health started working very closely with us and asking for our support and technical assistance that they scaled up because basically they don't have enough personnel to do everything that needs to be done. We have experience doing this. We've developed tools. We know how to facilitate this change, and they just need human power to kind of keep going. So we've now gone to over 25 regions of Peru, assisting that Ministry of Health with some of the follow-up, some of the questions, some of the times that the cancer coordinators in each region are facing a barrier. Like we say, yes, we had that same barrier. This is how we handled it. So that's been wonderful. And we've developed tools such as the one that you see here. When people said, but you need to take them to colposcopy, you need to have some way to diagnose, to make sure that you're not treating women just because they have a virus. We would show them based on their numbers, based on their services, based on the number of people that can offer colposcopy in the hospitals. We would show them like we are going to be having, for example, in this case, we're going to have 214 positives every month. Right now, you're doing 40 colposcopies a month. Can you really treat 214 every month? And if you can't, and this was actually an overestimate, if you can't, that means that every month there's going to be 80% of the women who are not going to even be able to get seen because you just don't have the capacity. So do you really want us to send everyone to you to create a huge bottleneck that's only going to get bigger every month? Or do we do something at the primary level? Do we strengthen that primary level to make sure they can get that? And that's so every time a new doctor would come into town and be like, what? You're not doing colposcopy? We would show them this image and we'd say, this is the reality. This is the contextual reality. And in certain cities, this is not the same, but this is the reality here. And we would quickly map it out. And the funny thing is, I thought this was a problem in the rainforest, but then we started mapping out in Lima, the capital. They had very similar structural problems where bottlenecks get formed. So all of these different tools, this is a different tool we use, like to make the system visible, to say, okay, where are you going to do it? How are you going to get your sample from here to there? Where is the lab going to process it? How are they going to get the results back to the primary level? If the person needs thermal ablation, where are they going to go? Oh, they're going to do it here, but they don't have a colposcopy equipment. Oh, we could do it here, but they have the colposcopy equipment, but no gynecologist. You're like, okay, these are problems we need to solve, right? Like you have a colposcopy equipment in one, but the gynecologist can't work there. And they can't lend you the colposcopy equipment where you do have a gynecologist. I mean, these are system problems that are not going to be saved by the woman, dealt with by the woman. And now I'm showing you data over 5 years. And you see that we've had peaks and valleys and moments in time where during our project, you can see the first big peak is when we started, then we had COVID. Then we had a second big peak, then we had COVID again, and then we had procurement issues. And this is kind of when the project handed over to the Ministry of Health. And we're not saying this to say, oh gosh, look at what the Ministry of Health did. No, what we're saying is when we started handing over the system, there were other challenges to the system. What happens? Well, there were issues of like procurement, that things weren't getting there on time, distribution, things weren't being able to be distributed the way they needed to be. System changes, they moved to a different type of screening test and monitoring system. And all of this impacts how it can go forward. Is this a project failure? No, this is the reality. This is life. And what we now want to talk about is, yes, it was successful in parts. But this is long term what happens in a system. And it's not that people in the system are not trying to make sure it works. It's that like there are a lot of other challenges that come into play sustainable financing, sustained personnel, and all kinds of other challenges that we need to be aware of. When you're doing implementation science, it's not just about getting started, it's about how to keep it going. And that's one of the questions that is what I'm going to be working with in the next few years. So the other thing we need to think about is when we work in low and middle income settings, like, yes, there are new technologies, there are new strategies, there are new plans. The WHO gives more directives. But how do we plan for this? How do we implement it effectively? Because just getting a big guidance from the WHO is not enough to help a system change. You really have to invest a lot of time and energy. And a lot of time, a Minister of Health is the technical team is 2 or 3 people trying to manage this for an entire country. You just can't imagine. How are these new strategies diffused? Who is expected to digest this evidence and take it to practice? Can we have expert advice on the ground so that the planning and implementation is supported, not just a manual, and how do ministries know what type of evidence they should trust and who it should be coming for? And then there are other challenges. In from 2016 to 2022, we had 6 presidents in Peru. I mean, fortunately, this last one, although she's got a 1% approval rating, but we had 6 presidents in the time. We've had at least 17 ministers of health. I can't tell you how many cancer directors or how many regional cancer coordinators, but this constant turnover means that you can work with a team of people, you start making decisions, you start taking actions, and then there's somebody new. And you kind of have to start over again and over again and over again. And it's very difficult to do long-term planning changes because you saw from our data that it's not just a question of changing the system. You need to be there for another 5 years to make sure that every new challenge that comes into the system is handled so it really becomes sustainable. Changing it for 1 year is one thing. Changing it for 10 years really requires like a systematic process, and that's not possible. So, what can academia and universities do? We can be facilitators. We can help with that embedded facilitation and the accessible expert advice and help to create communities of practice where it's not just a one-off practice where I go and do that. I live in Peru. I'm Peruvian and I live in Lima. I'm Tulane faculty, but I'm based permanently in Peru. So I'm there. I can answer and respond quickly. But that's one, like how do we make sure that the regional cancer coordinators can be talking constantly and every time they have a problem, address it. Another issue is systems thinking. There's this whole field, systems thinking, complexity sciences that we really need in all fields of study. It's kind of like the ecology concept, that it's an ecosystem that functions and you don't just have predators, you have prey, and you don't just have this, but you have to have the whole ecosystem working for survival of the species, right? And for when you think of a change to something in a health system, you have to understand that health system is complex. And when you make one small change, there's going to be a lot of repercussions downstream. When you make 5 big changes, there's going to be a lot more repercussions. And there's going to be some people who resist that change, right? When you tell the person who does PAP technology and interprets PAP readings that they're no longer going to be using pap smears as much, they're going to resist it. They're going to be thinking that they're going to be left without a job. So what can we do to ensure that people are understanding there's a whole picture? Collaborative partnerships. One of the advantages with this is that despite the fact that there were 17 ministers of health and presidents and coordinators and all sorts of stuff, we stay, right? And if my project failed, if what we did failed, I'm still going to stay. I'm still going to be there. So we can test what works and what doesn't work. And we can keep that sustainability. And if you create partnerships so that even if there's a lot of turnover, I mean, I think about things like climate change, where you really need to be thinking 20 years in advance. When you have this constant turnover, who's going to want to spend their 6 months working on something that will not see maybe any impact or benefits for 20 years? They want to say, my legacy is I got this going. So we really need these partnerships that allow us to think of long-term issues. Future directions, I'm almost done with my slides, but the future directions from international institutions, it's this exchange of ideas, new voices, new perspectives from the ground and from different settings. This accessible expert advice, from the ground and from the experts. The WHO has certain expert advice, but the people on the ground who are implementing it also have other advice to give. The importance of funding longer projects because it takes time to build trust and to make these changes, and you can't make them sustainable in 1 year. Issues of supply chain are major problems in LMICs, low and middle income countries. Capacity building, continuing education, that's a problem. Data systems. So these are future directions that we need to keep in mind as we change health systems. Ultimately, I want to end by saying, equity requires innovative strategies. We cannot use the same strategies for all. We need to be innovative in the strategies we bring in. We need to bring these strategies to the most vulnerable people. Public health is not about what is the best thing for that one person who can afford it. Public health is about what's the best thing we can do for the most people, right? It's a population level focus. So equity requires innovative strategies that bring screening and treating to the most vulnerable women, the most vulnerable regions, using implementation science for this adaptation and scale up if we hope to reach global elimination of cervical cancer. Again, those are those school buses in this region. This picture captures it all. And I want to say that this brings me hope. And when I think of all the people who have been impacted and affected by this project, I mean, these are collaborators, but then I think of the number of people that have been reached. It brings me hope. This picture brings me joy. This is a boat of people coming to one of these ships to get their treatment, right? So you see here the screening, the picture showing screening for cervical cancer. And I'm not saying everybody on that boat was going to get screened for cervical cancer, but what I'm saying is it brings me joy to see that we can reach a population that has been completely forgotten and underserved over the years. I also want to end by saying that this by no means has been my project in any way. Dr. Patty Gravitt and I were the PIs for the first 5 years, and it's had a big turnover of people, but some of the most constants have been our program champions like Graciela Mesa. The list is here, the stakeholder group. This would have not been possible. Every time I ran into a problem, I'd go to Graciela and she'd say, I know that person. He was a student of mine. They would change things. So it's taken a humongous collaboration of people on our team, Joanna, Christina, Lauren, Lucia, Cecilia. I mean, it's been a big group. Some of them have been Tulane students like Magda here on this chart. And some of them have not, but it's been a big work in progress. And I want to end by saying, we could have gone faster had we done this alone. If we had set up our own NGO to do one little clinic and fund it and get as many people screened in possible time, but it would have not been sustained in any way possible, right? And if once our funding ended, it ended. And in fact, when we started our project, people said, I don't want to do this project because, you're going to come, you're going to fund us for a while, and then when you finish, you're going to go, So I want to end with saying, if you want to go fast, go alone. But if you want to go far, it may be slower, but go accompanied and it will be a much more sustainable issue. So with that, I end, and I want to make sure that people have time for questions. Thank you.
Thank you so much, Dr. Sedan. So at this time, if you have any questions, please feel free to drop them in the Q&A chat.
And I'm going to try to see how I get to that Q&A chat. Let's see.
So I have a question. It just came up. They sent it directly to me. Were you concerned that the woman who administered the swab testing on their own would do it correctly?
Yes. No, I was not concerned. So data shows that the sensitivity of the test is pretty reliable regardless of who does it. But it's a great question because a lot of the midwives, what we noticed that there were a lot of midwives who said, there's no way they're going to do it as well as I do. I will do it, right? Or they would say, I want to do the swab myself because I think that I can also be checking her cervix and seeing if there's anything else I need to be checked for. What we found, though, is that midwives in rural areas said, this was the best thing that happened to me because I don't have a gynecological table in my facility, or for me to reach women in those remote areas, I have to bring them to my health facility, and that's almost impossible. So they were like, this is great, number one. And number two, you know, a lot of the midwives, we ask them to try it doing themselves, and you introduce this swab until it kind of gets to a natural stopping point, and then you say, turn it around a few times, 3 times, just do a few circles, and then and you're picking up virus particles, little. So it's not an issue, and a lot of it depends on the professional giving reassurance that you're going to do it just fine.
So the next
Tell me
question,
you guys have questions.
yes, what is the percentage of vaccinated people you had?
Okay, that's a great question too. Peru started HPV vaccinations around 2011, 2012. That group of young women were not going to, the HPV testing starts at 30 and it kind of ends till 49 in Peru. Why does it start at 30? If we did HPV testing of 25-year-olds, 22-year-olds, it would be high. About 80% of men and women will have been exposed to HPV at some point in their lives. Not all of them are and HPV has a lot of different types. Some of them create genital warts. Some of them are not malignant in any way. And some of them are oncogenic, which is they have a higher risk for developing into cancers, such as the HPV 16. So a lot of people in their 20s will eliminate it on their own. Great, which is why we don't test people in their 20s, because most of them will eliminate on their own. We would scare half the population or more into thinking they've got a problem. But by 30, and it's not a magical number, but around 30, your body should have eliminated the virus. And if we're assuming that you're beginning to go into more stable partnerships, etc., your body should have eliminated. And if it hasn't, then and it may be many reasons. It's just one of the stigma issues that people said, oh, it's because they're having a lot of partners, their partner's unfaithful, they've had a lot of sex. It's not about stigma. It's about like some people manage to eliminate it and some people don't manage to eliminate it. And those who don't eliminate it, sometimes it's because they have other co-infections with parasites, with whatever it may be that makes their body have a more difficult time eliminating it. So what we are trying to do is the best thing you can do to prevent cervical cancer is screen yourself. That's the best thing you can do. So if you go back to the question you just asked me, if girls were being vaccinated up to the age of say 13, by 2011, when we started this project 2018, 7, 8 years later, the women that were vaccinated were in their early 20s. So the women that we were screening had not been vaccinated. They were 30 to 49 years old. Vaccination is actually quite high in Peru, and it's school-based. So they tend to enter into the schools through the vaccination. But of people listening to this presentation, you can get your HPV vaccination, and it's extremely effective, and it is really Scotland and Australia are showing evidence of being able to eliminate cervical cancer just with this high levels of vaccination.
So the next question is, do you think a language barrier was a challenge?
In our case, not really, because my entire team speaks Spanish. We're Peruvian. The only one in our team who wasn't fluent was the co-PI, the other PI in this project, Patty Gravitt. So we didn't really have an issue. Now, where we did have some issue was when we did those ships navigating down the Amazon and the tributaries. And in those ships, they have community liaisons that go out that often speak some of the native indigenous tongues. That said, there are dozens of indigenous languages that we would not reach all, but these community liaisons are used to like working with different community groups and cultural groups. And they did a lot of that initial, I don't want to say recruitment, but that initial awareness building that this program would be helpful for women. So the answer is no, we didn't really have a lot of language issues.
The next question, has there been any replications of this program in surrounding countries?
Well, great question again. We have talked about scaling this up to other countries, Colombia, Bolivia. The truth is that Peruvian Ministry of Health is scaling up this same approach. They also recognized that colposcopy was not going to be feasible and everywhere, so they've taken on this role. This evidence also WHO recommends if you can't do colposcopy for everybody, go ahead and do some kind of treatment. Don't leave women hanging. So first of all, we're beginning to see, one region, Bolivia is beginning to do HPV testing. Most of South America is beginning to move towards HPV testing. And right now I'm involved with another project with Dr. Troy Moon here at Tulane University, Tropical Medicine and Infectious Disease. He's carrying out a very similar project in Mozambique. And so wonderfully, he's invited me to be a consultant on that project because again, we've learned a lot from doing it, what kind of barriers they may face and and how we handle them in that process. And that's what implementation science is all about, right? It's about like what knowledge that we've developed or generated is generalizable and could be used in new settings. And how do we translate that into a new setting? So for example, the swim lanes that I showed you in one of those diagrams where it showed you how do we reduce steps? We just did that in Mozambique 2 or 3 weeks ago. We showed them this is your system right now. What do you do to reduce steps? And so it's great to be able to see that after like hitting your head against the wall, trying to figure out what's the best way to make change or facilitate change, that you finally say, this tool really works well. And then you go to another country and you can start off with the right foot because you've already tested it like too many times in one setting.
Next.
And actually, one more thing, sorry. I'm actually part of this action group, Cervical Cancer Elimination Action Group. And there's people from Cameroon and Ghana and Nigeria and Nepal and Mexico and different countries that are part of this action group. And they're implementers and implementation scientists in this group. And we meet once a month to discuss some of the challenges they're facing specifically for that, to exchange like, hey, I tried this in Peru, this worked, and hey, I tried this in Mexico. So we are trying to scale up this in different regions.
So Dr. Paz, so then you got a lot of questions.
Oh no.
Yeah.
Do we have more?
Yeah, we got time. We can answer these questions.
Okay.
The next question is, this is such a fantastic but pragmatic approach to reaching out to women in remote areas. I would wish to know if the country has access to chemotherapy and is it free for women diagnosed with cervical cancer? What about radiotherapy? Is it available and is it free?
Another excellent question. So indeed, we have chemotherapy and we have radiotherapy, but guess where it's located? Like it's not in the jungle, right? So actually about 5 years ago, the main hospital of Loreto, that's big state, did create a chemotherapy room and they do offer chemo. The problem is that they don't have a full-time oncologist. In fact, right now they don't even have an oncologist or unless, so in the 5 years or 6 years or 8 years that I've been working with that hospital, they've only had oncologists at one point for about 8 or 9 months. And now that oncologist moved on to a different country because he wasn't getting paid the way he needed to be paid. So it's a system failure, right? When you have an oncology unit without an oncologist. So there's one from an employer-based hospital that comes twice a week or 3 times a week for a few hours to help manage those cases as a goodwill approach. But radiotherapy, nope, there's no radiation like radiotherapy bunker. There's nothing we can use. So that's the big problem. If you get cancer and you have to be taken to Lima, let me start over again. The screening is free, except that when you go to get screened, sometimes they don't have speculum or they don't have such and such. And they say, okay, you need to go to the pharmacy and buy that and come back, right? Okay, so it's free, but sometimes there's some things missing. Okay, fine. Then you get recommended chemotherapy. It's free. The system provides it, the Ministry of Health. But if you don't have it in your region and you have to go to Lima, they may pay for the patient to fly if it's something urgent, but they won't pay for the family member who flies. They won't pay for the family member who stays to accompany that patient. They won't pay for the housing, the food, all that sort of stuff that a patient might need to advocate for themselves. If they're indigenous, they may not even speak the language, let alone try to fly on an airplane to Lima. So I just think, for the audience who's here, if you got a really major life-threatening disease, imagine being told, that you have to fly to Australia because your disease is best handled in Australia. it's overwhelming to think of, like, I've never used the Australian health system. I don't know where I would go. I don't know where I should stay. Who should I call? Who should I talk to? Where do I stay? So that's what it was. That's the equivalent of what it's like for somebody living in the rainforest to think about going to Lima. So the answer is there is a chemotherapy unit without an oncologist. There's no radiation therapy. There are 3 places in Peru that supposedly offer chemotherapy and radiation. The National Cancer Institute in Lima, and 2 regional institutes, and they're trying to build more, but that's going to take a while.
Next question. How can you ensure that everything you've accomplished continues to be maintained in the future, even if you're not there to oversee it?
Well, first of all, one of our big folks, and this is why I said go far, go accompanied. None of that what I've done uh, has been alone. We have worked very closely with the Ministry of Health, with cancer coordinators, and I'm really, really, really hoping, with the best of my heart, that some of the approaches that we took of mapping out systems, of swim lanes, of developing tools, of making data visual, of bilateral exchange, not doing this one-off experience. I hope that that stays in the system. And I remember after one of our workshops where we were mapping out the system, somebody said, wow, like I could do the same thing for malaria. And I said, absolutely, and I could do this for breast cancer and colon cancer. Absolutely. So what I'm hoping that we're doing is building capacity and how to think through these issues and how to ask the right questions and how to be thinking about what can be done differently. And, it doesn't happen overnight. Um, I live in Peru. I will be there. So it's not somebody that comes in every 6 months and comes and talks. No, I'm there. And even if this project ends, it's not like if somebody calls me up and says, I'm stuck here, I'm going to say, well, the project ended, so I'm done. Like it's not going to happen like that. Um, but indeed, that is sometimes the issue with some funding when the researchers are not on site, like it's kind of out of sight, out of mind, and that's not the case here. But I do repeat what I said, which is a lot of funding cycles, like for example, from the NIH or from different groups, is 5 years. And is 5 years enough to get started, to build trust, to get the system changing? We were lucky to get a second 5-year term, but it really takes a while to build this. And if you really want to be sustainable, you need to be able to get funding that really allows you to carry on for a little longer or a lot longer.
Is it possible to have created an NGO whilst working towards sustainability?
We worked through an NGO. So I'm just going to say we did work through one. There's an NGO in Peru called Prisma, and they helped us hire some of the people. They have people who've done a lot of community-based work. Could we have created within Prisma, or using that same model of question, could we have created this NGO? Again, we were working directly with health authorities, and those health authorities change. But in Iquitos, it's, as you've seen on the map, it's almost like an island within this trees, and what we have found is that a lot of times people change hats, but they're still the same people around. So I do hope that some of the issues are pushed forward through these different authorities. The rapid change of the system is always going to be a problem. And that's why you really want to make the system as self-sufficient and systematized as possible, which is not possible to do in 2 years. You really need to make almost everything be very automatic. Like, how you probably guys don't know because you probably never used a checkbook, but in the past, you used to get 10 checkbooks from your bank. And when you were done with the 8th one, there was a little slip of paper before your 9th checkbook, and it said, it's time to reorder checks. That's the kind of stuff that we need to have in our systems. It's kind of like you're about to run out of duplicate copies. You're about to run out of your speculums. You need to have something very systematic. So it's press a button and it happens. And I do hope with automatization of some of these processes that we can do that. But I'm not sure. I'm not sure how different it would have been with an NGO and we. I will also say one other big difference or difficulty is that even the people on my team um, change. I have a lot of students who come down and work with me for 3 months. Some came for a year, like Magda, some come for 6 months. But even that means that there's a lot of turnover even within my institution. The Peruvian medical students that work with me finish up going to do residencies elsewhere. So it's a lot of effort to maintain that. So anyway, I don't know if that answers your question.
So this question, thank you so much for the presentation. I am a Colombian student with a strong interest in women's health. Based on your experience, what are some of the biggest lessons you learned from implementing this program? And how could these insights help guide similar initiatives in other countries across the Amazonian region?
So what I was saying, we need to collaborate. We need to learn from each other. This worked, this didn't work. Don't spend too much time doing this because um, because we've already tried that in Peru and it really didn't help. Use this tool. Or I've learned make data visual, don't do a one-off. In fact, we did what's called a realist evaluation of our project. And a realist evaluation means you're looking for the underlying principles or mechanisms that made this work. One of the things that we found was that the one-off, where you go help somebody change it and leave, it was poorly talked about. They said you are one of those projects that came to Peru or that was based in Peru, but you came and you stayed with us. You held our hand throughout the process, which is why every time we banged our head into a wall, like, a new barrier, you guys were there to help us work through it. So in terms of your question about Colombia, don't do a one-off. We need to like have people on the ground who can keep pushing this forward. We need to make sure that, when you get funding, like you can start off as quickly as possible because it takes time to make these changes. When I was in Mozambique, I was impressed because they have they already use VIA for everything and they already have thermocoagulators, which we didn't have in Peru. So as they're making this change into HPV testing, the money that they use for PEPFAR for the HIV/AIDS programming has really helped to develop a fairly good infrastructure to make this change happen. And that's fantastic, right? So they will have less changes to their system than what we had to do. But in Colombia, in Bolivia, in Ecuador, we need to accompany each other and we need to learn from each other. I'm beginning to see some questions here myself.
Yeah.
What was the rescreening? The rate of rescreening during the implementation period. Our policy, the Ministry of Health, when we were doing this, just said, come back in 5 years. We didn't do that. We started doing rescreening every year, but the number of women who came back was very small. I mean, I think if we had 1,000 positives, we had about 130 who came back. I mean, so 10%. So what it tells us is that like we need to do more of an effort of if you get screened and you get treated, you really need a follow-up. And also we were hoping that our ablative therapy would keep more people negative, but it's still 2/3 become negative, but there's still 1/3 of women that are positive after a year, even after receiving this ablative therapy. So that's one comment. And the second part to your question is that we did a lot of qualitative work throughout this process. Every time we ran into, you know, questions about like, why are only, 10% of the women coming here? Why are so many women being lost to treatment? We would go and find women and we say, okay, you were supposed to go to the hospital within 3 months and you haven't gone, like you haven't received your follow-up. What happened? And that's where women would say, I went to get my appointment and they didn't have the calendar for the next month. So then I went a second time. It took me 3 hours to get there and 3 hours to get back home. I went a second time. I got my appointment this time. Yay. I came back for the day of my appointment and oh shoot, the doctor is in Lima and we have to reprogram it. You can't complain. We just reprogram. You reprogram it. You come back for the reprogrammation. There is a strike in the hospital. Okay, reschedule, come back. Oh, your reference sheet that last 2 months from the primary level needs to be reissued because it's been 2 months. So you need to go back to the primary level, get another reference sheet, and come back. So we found that people were taking 6 or 7 times. One woman even had gone 13 times before she actually got seen. So it just shows you that, and the importance of coupling the quantitative with the qualitative, because the qualitative tells you a lot of what's happening. So yes, we did use a lot of that. How did Tulane support me in this endeavor and have other institutions try to engage us in this project? The grant that we got, the initial grant that we got was an NIH NCI funded grant. And so we got it. It actually went to my PI's institution, but so Tulane has helped me by giving me the time to work on this project. I've had Tulane students come and work on different papers associated, doing some of the qualitative work. I had a student, Alex Blum, who was a UNC, Johns Hopkins, Morehouse, and Tulane Global Fellow. And in fact, if any of you is a graduate student at Tulane right now, the application for that is going to be next week, if I'm not mistaken. But it's a fellowship for pre-doc and postdocs who want to spend 1 year outside the country. And so we've had several of those who came and worked on a specific part of the project, and that helped us to get like specific bits of the data out in time, because again, the management of this has been huge. And so it's been really hard for me personally to be doing a lot of writing, although I have, but it's been hard to do as much writing as I'd like to because of the management. And so for the final question, that you want to read it out, Cassie?
Yeah, sure. Are there any contextual differences within different locations in the study area where the project had or has to be modified to suit that particular location?
Yeah. So context matters, right? Especially when we talk about implementation science, context matters. You can't use the same approach everywhere. We mentioned there was no chemotherapy, no radiation therapy, no, that's in Iquitos, the capital of that state. So even there, you had to fly to Lima. If you lived in a remote region, like, you may not get to see a health professional who can handle this except once a year, if that. So, the way you manage cases really varies. So, for example, for the doctors who kept pressing, you need to do colposcopy, you need to do colposcopy. Fine, you can do colposcopy, but do it in places where there is actually a colposcopist and where there's a colposcopy equipment, because it's not possible in certain regions. So yes, as we talk about the kinds of screening and treatment models that we need to develop throughout the world, whether it's in Colombia or Malawi, we need to be thinking about, like, what are the different options that we have? We need to be contextually relevant and feasible. I am not going to tell people to do colposcopy if there's no colposcopy equipment anywhere. If there's no colposcopy machine, if there's no colposcopist, you need to be adaptable, and you need to say, okay, in the case that you don't have this, go to plan B. And if plan B doesn't work in your context, go to plan C. We definitely need to be adaptable. But for that adaptation, it also helps to have experts who can say, you are here, so let's move forward here and discuss, because that expert might say go this direction, and the person on the ground might say, yeah, but that's not possible either because of this. So absolutely, context matters. Thank you so much.
Well, thank you so much, Dr. Pasadan, and thank you all so much for tuning into today's seminar series. Thank you all for even allowing us to go over 14 minutes, but you all had amazing questions, and I just could not end it without all your questions being answered. So thank you all so much. You all have a wonderful day, and thank you so much, Dr. Pasadan.
Thank you. You're welcome.